Good evening. This is a presentation about practical and basic knowledge and use. This relates to interpretation of ECGs. And in order to begin afresh, I'd like to go through with anatomy, embryology, physiology, and then going on to various conducting mechanisms of action potentials, which lead us to better understand rhythm disorder and disorders relating to individual components of the ECG. So we go further with the ECG presentation, and I intend to describe briefly about the anatomy and embryology, followed by the structure and the format of the cardiomyocyte and the physiology of action potential in that being produced and being conducted along specialized fibers. It will then go on to explaining how the impulse generation and conduction affects the character of the 12-lead ECG. And then we'll describe about the shape and the implications of P wave, PR interval, supraventricular tachycardia, and atrial fibrillation. The second part of the ECG presentation will include disorders relating to QRS, ST elevation and depression, T wave normality and abnormalities, and then it will also include numerous examples of various ECGs that we should be able to interpret broadly and be able to compare with the normal ECG presentation as it is normal. So the heart begins quite early in life, and around 18 to 19 days of fertilization, it develops from the anterior splanchnic mesoderm, which differentiates into mesothelium, which is like the tuna externa or the pericardium, the myocardium or tunica media, and then endocardium or endothelium comparable to tunica intima. This is the first functioning unit which is developed by day 21 of fertilization and is actively beating and pumping blood. A week later, it develops, due to fusion of tissue masses, various septas, which at this stage are called endocardial cushion, and they lead to the formation of septa and valves. The tubular heart, having generated from the primitive cardiac cells, now develops into a tube. And by 6 weeks, it has an arterial and a venous outlet. So this is the splanchnic mesoderm, the cranial end, and these are the small islets where the progenitors of cardiac cells develop. Subsequently, it develops on both sides and fuses in the middle. So the cranial part deals with the arterial flow, outflow to the body, and the caudal end collects venous blood from various parts. Then, as a result of the bulbous enlargements, it becomes bulbous cordis, and subsequently, due to cranial caudal migration of cells and twisting on the sides as well, it develops its shape as it is subsequently found in the thorax. So, what does the heart muscle consist of? What is it? So, the cardiac myocyte is behaviorally an involuntary muscle fiber with many of the characters of the skeletal muscle fibers. It has, of course, one cell, cellular nucleus, and abundance of mitochondria. And the adjacent cardiomyocytes have a gap junction, which is crossed over by the action potential, like they would do so jumping from one neuron to the other. The progression of electrical impulses takes place because the membrane overlying the cardiomyocyte is negatively charged, with the interior of the cell being relatively more negative than the outside. So due to the pumping action of various transport mechanisms, the regenerated positive elements go down towards the cell, making it less negatively charged. In other words, this has now become activated. And therefore, it would be able to transmit an impulse. So the cardiomyocyte can generate action potential on its own, and it also can transmit it between muscles and along the length of the muscles. So it is fairly different in the sense that it does produce action potentials, and it can also act as a conducting fiber. It does so very quickly. So where does the energy come to the cardiomyocyte? After all, it's working constantly, and it's the hardest working muscle, which pumps from each atrium or ventricle 71 grams of blood per beat, leading to 2,500 grams of blood per day, and beating and contracting 3 billion times in the lifetime of a person. So the energy of the myocardium comes from the oxidative mechanism involving the metabolism of fatty acid, which gives the most of the energy. It also aerobically comes from the metabolism of glucose and anaerobically from lactose or lactate, although that is of a small degree. The cardiomyocyte is highly vascularized, and if one compares it to the tunica media of a large artery, then vasa vasorum additionally supplies further nourishment through the local arterial blood supply. Because it is metabolically very active, it requires numerous mitochondria and glycogen. So, cardiomyocyte or myocardium is the hardest working muscle, and it pumps 71 grams per beat, 2,500 grams per day, and it beats 3 billion times in the lifetime. Normally, the rate of the heart is 70 per minute, and it contracts and relaxes 100,000 times a day. During the phases when it has finished contracting, the shortest of pauses is enough for it to rejuvenate again. So the cardiomyocyte is surrounded by a membrane called sarcolemma, and this therefore acts as a generating electrical substance as well as a conducting one. The neurological excitation and transmission takes 1 millisecond, whereas the cardiac action potential is 200 times faster as 200 milliseconds. And of course, the action potential develops due to the ion shift, which leads to a voltage change. Much of the action potential is produced by a selective area called the cardiac pacemaker or sinoatrial node, which depolarizes below the threshold due to the calcium ion and potassium moving inwards. The gap regions between the cardiomyotome releases acetylcholine along the length of the muscle fiber. Calcium is released into the sarcoplasma, which is actin, which is thin, and myosin, which is thick. And these are regulated in terms of their actions by troponin and tropomyosin. So we'll now look at the conduction fibers and how they produce the shapes of the ECG, and also whether the generation of current from the sinoatrial node is replicated by other parts of the cardiomyocytes in the atria.
The cardiac conduction system consists of the following components: the sinoatrial node, or SA node, located in the right atrium near the entrance of the superior vena cava. This is the natural pacemaker of the heart. It initiates all heartbeat and determines heart rate. Electrical impulses from the SA node spread throughout both atria and stimulate them to contract. The atrioventricular node, or AV node, located on the other side of the right atrium near the AV valve. The AV node serves as electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles. This delay is to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. The AV node receives signals from the SA node and passes them onto the atrioventricular bundle, AV bundle, or bundle of His. This bundle is then divided into right and left bundle branches, which conduct the impulses toward the apex of the heart. The signals are then passed onto Purkinje fibers, turning upward and spreading throughout the ventricular myocardium. Electrical activities of the heart can be recorded in the form of electrocardiogram, ECG, or EKG. An ECG is a composite recording of all the action potentials produced by the nodes and the cells of the myocardium. Each wave or segment of the ECG corresponds to a certain event of the cardiac electrical cycle. When the atria are full of blood, the SA node fires, electrical signals spread throughout the atria and cause them to depolarize. This is represented by the P wave on the ECG. Atrial contraction, or atrial systole, starts about 100 milliseconds after the P wave begins. The PQ segment represents the time the signals travel from the SA node to the AV node. The QRS complex marks the firing of the AV node and represents ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave is produced by depolarization of the main mass of the ventricles. S wave represents the last phase of ventricular depolarization at the base of the heart. Atrial repolarization also occurs during this time, but the signal is obscured by the large QRS complex. The ST segment reflects the plateau in the myocardial action potential. This is when the ventricles contract and pump blood. The T wave represents ventricular repolarization immediately before ventricular relaxation, or ventricular diastole. The cycle repeats itself with every heartbeat.
The heart is essentially a muscle that contracts and pumps blood. It consists of specialized muscle cells called cardiac myocytes. The contraction of these cells is initiated by electrical impulses known as action potentials. Action potentials start in pacemaker cells, then spread to contractile myocytes and stimulate them to contract. An action potential is essentially a brief reversal of electric polarity of the cell membrane and is made possible by the flow of ions in and out of the cell through specific ion channels. In a resting cell, the membrane voltage is usually negative, meaning the cell is more negative on the inside. An action potential is typically composed of a rising phase, depolarization, followed by a falling phase, repolarization. The depolarization phase is the result of net influx of positively charged ions. Membrane voltage increases and becomes less negative. The cell becomes less polarized or depolarized. The repolarization phase is due to net efflux of positive ions. Membrane potential becomes more negative. The cell is repolarized back to its original resting state. In cardiac myocytes, there is also a plateau phase which occurs when the efflux of one positive ion is balanced by the influx of another, and membrane potential remains relatively unchanged. This is when muscle contraction occurs. An action potential waveform reflects electrical events in a single cell. Pacemaker cells and contractile myocytes exhibit different forms of action potentials. Action potentials spread through different regions of the heart in a sequence that follows the cardiac conduction pathway. Basically, the impulses start in the SA node, the primary pacemaker of the heart, then spread through the contractile myocytes of the atria to reach the AV node. The AV node passes the signals onto the AV bundle, then bundle branches, Purkinje fibers, and finally the ventricular myocytes. Myocytes from different layers of the heart wall, the epicardium, mid-myocardium, and endocardium, exhibit different rates of repolarization due to different ratios of ion channels. Electrical activities of the heart as a whole can be recorded in the form of surface electrocardiogram, ECG or EKG. An ECG is a composite recording of all the action potentials produced by the cells of the heart. Each wave or segment of the ECG corresponds to a certain event of the cardiac electrical cycle. P wave represents the sum of depolarization in all atrial myocytes. The QRS complex reflects ventricular depolarization. Atrial repolarization also occurs during this time, but the signal is obscured by the large QRS complex. The ST segment reflects the plateau phase of action potentials in ventricular myocytes. This is when the ventricles contract and pump blood. T wave corresponds to ventricular repolarization that occurs immediately before ventricular relaxation. The peak of T wave reflects repolarization of epicardial cells, while the end of T wave corresponds with repolarization of mid-myocardium. The cycle repeats itself with every heartbeat.
A faster heart rate of greater than 100 beats per minute. Sinus bradycardia and sinus tachycardia may be normal or clinical depending on the underlying cause. For example, sinus bradycardia is considered normal during sleep, and sinus tachycardia may be normal during physical exercises. Cardiac arrhythmias that originate from other parts of the atria are always clinical. The most common include atrial flutter, atrial fibrillation, and AV nodal reentrant tachycardia. These are forms of supraventricular tachycardia, or SVT. Atrial flutter, or A-flutter, is caused by an electrical impulse that travels around in a localized self-perpetuating loop, most commonly located in the right atrium. This is called a reentrant pathway. For each cycle around the loop, there is one contraction of the atria. The atrial rate is regular and rapid, between 250 and 400 beats per minute. Ventricular rate, or heart rate, however, is slower, thanks to the refractory properties of the AV node. The AV node blocks part of atrial impulses from reaching the ventricles. In this example, only 1 out of every 3 atrial impulses makes its way to the ventricles. The ventricular rate is therefore 3 times slower than the atrial rate. This is an example of a 3-to-1 heart block. Ventricular rate in A flutter is usually regular, but it can also be irregular. On an ECG, atrial flutter is characterized by absence of normal P wave. Instead, flutter waves or F waves are present in sawtooth patterns. Atrial fibrillation is caused by multiple electrical impulses that are initiated randomly from many ectopic sites in and around the atria, commonly near the roots of pulmonary veins. These unsynchronized chaotic electrical signals cause the atria to quiver or fibrillate rather than contract. The atrial rate during atrial fibrillation can be extremely high, but most of the electrical impulses do not pass through the AV node to the ventricles, again thanks to the refractory properties of the cells of the AV node. Those that do come through are irregular. Ventricular rate or heart rate is therefore irregular and can range from slow, less than 60, to rapid, more than 100 beats per minute. On an ECG, atrial fibrillation is characterized by absence of P waves and irregular narrow QRS complexes. The baseline may appear undulating or totally flat depending on the number of ectopic sites in the atria. In general, larger number of ectopic sites results in flatter baseline. AV nodal reentrant tachycardia, or AVNRT, is caused by a small reentrant pathway that involves directly the AV node. Every time the impulse passes through the AV node, it is transmitted down to the ventricles. The atrial rate and ventricular rate are therefore identical. Heart rate is regular and fast, ranging from 150 to 250 beats per minute. Ventricular rhythms are the most dangerous. In fact, they are called lethal rhythms. Ventricular tachycardia, or VTach, is most commonly caused by a single strong firing site or circuit in one of the ventricles. It usually occurs in people with structural heart problems such as scarring from a previous heart attack or abnormalities in heart muscles. Impulses starting in the ventricles produce ventricular premature beats that are regular and fast, ranging from 100 to 250 beats per minute. On an ECG, VTach is characterized by wide and bizarre-looking QRS complexes. P wave is absent. VTach may occur in short episodes of less than 30 seconds and cause no or few symptoms. Sustained VTach lasting for more than 30 seconds requires immediate treatment to prevent cardiac arrest. Ventricular tachycardia may also progress into ventricular fibrillation. Ventricular fibrillation, or VFib, is caused by multiple weak ectopic sites in the ventricles. These unsynchronized, chaotic electrical signals cause the ventricles to quiver or fibrillate rather than contract. The heart pumps little or no blood. VFib can quickly lead to cardiac arrest. VFib ECG is characterized by irregular random waveforms of varying amplitude with no identifiable P wave, QRS complex, or T wave. Amplitude decreases with time from initial course VFib to fine VFib and ultimately to flatline.
So we saw the electrical conduction being made from sinoatrial node, and then it went on to the AV node and then down to the rest of the ventricle. We are now going to have to look at the ECGs. And this is a 12-lead ECG. And obviously, it's been made with various leads that we can see printed here. Lead 1. And this is lead 2, lead 3, and then a long lead 2, followed by the AVR, and then AVL and AVF, and then V1 to V6. So we need to understand what the parameters are of each lead. So the ECG travels at the rate of 25 millimeter per second, and that the calibration is such that 1 millivolt will lead to 2 of the 5 large boxes. So each is 5 small sized squares. And so 1 millivolt is 1 centimeter. And so the small square is all to do with smallish thing. So the large squares consist of 5 small sort of lines. So these are five small squares, both on the sides as well as going up. And so, of course, each small square represents 0.04 second, and each large square represents 5 times that, so it's 0.2 second. And so the large square is 5 millimeter. That means 0.2 second. 5 large squares will make 0.2 multiplied by 5 and then multiplied by 60 seconds as 300 per minute. So therefore, if we look at the large squares, so each square is 0.2 second. And so we can time each one of this accordingly. So when we look at the large square, if the QRS or the R part of it is repeated in one large box, then the rate is 300. 2 large boxes, 150, 100, 75, 60, 50, 40. So these are easier to remember. And the limb leads are 4 limb leads, plus a lead on the right side of the chest, a lead on the left side of the chest, and a lead representing the foot, which is caudally. And 6 chest leads, V1 on the right side of the 4th intercostal space, just next to the right side of the sternum. And then it goes on to V6, 7, and 8. The V6, V1 to V6 is the standard lead of the chest wall. And if additional study is to be made of the posterior surface of the heart, particularly relating to circumflex artery or its ischemia, then leads 7 and 8 are also used. So limb leads are lead 1, left arm, right arm, lead 2, right arm, left leg, and then lead 3, left leg, left arm. The right leg is neutral. The right side of the chest used to be called AVR, and now it is right arm, which is an average of left arm and left lead contents. Similarly, VL is on the left side, VF is at the bottom. So looking at the chest lead, this is lead V1, and then this is lead V2, and then mid-clavicular line is lead 4, and between the lead 2 and lead 4 is lead 3, anterior axillary line is lead 5, and then the mid-axillary line is lead 6. So if you see this, it is easy to understand that not each lead is the same. So lead 1 is absolutely to the left side. As you can see, everything is upright. P is upright, QRS is upright. This is a small width QRS, T is upright. And lead 2 is the same. Everything is upright. Lead 3 is still the same, but the P wave is very small in size. And then, of course, the lead 2 is similar. VF has got a small P wave and upright QRS, upright T. The only difference is in the VR, which is the right side of the chest wall towards the right shoulder, the S wave is downsloping and T wave is inverted. This is normal for VR. The only other lead which is like that is V1. So if we look at the chest leads now, V1, which is on the right side, has predominant S wave, but upright T wave. And then you can see the progression of the QRS going slightly up as we go from V2 to V3 to V4 to V5 to V6. Now we go on to the actual P wave. So the P wave is the first positive deflection representing the atrial depolarization from the right atrium to the left atrium, and that it depolarizes as 0.04 and it goes on to 0.12. So the PR interval would be 0.12 to 0.2. This has a smooth contour. It's monophasic in lead 2, biphasic in V1. P should be upright in 1 and 2, and it should be less than half of the big square, so it is 2.5 millimeter. And the first 1/3 of the P represents the right atrium activation, and the last 1/3 is left atrial activation. So this is what one means by that. So this is the P wave, and the first part of the P wave, which is the early part of the onset, is right atrium, and the second part is made by the left atrium. So therefore, in lead 2, you see an upright P, which comes down into near the QRST complex. And in AV1, or that's the first chest lead, you would see that the right atrium is predominant as upright, and then the left atrium is downsloping like that. So all of this bimodal is the P wave. And so what happens if the right atrium is hypertrophied? Then in the lead 2, you see a tall P wave, and that this is now predominantly, first part of it is the right atrium, and the bottom part is the left atrium. In the V1, you would see that the P wave is actually inverted, and then it has gone down to the Q. So with the right atrial hypertrophy, you see the first peak of the P, then a downslope, and the second peak, which is of the left atrium. And in V1, you would see that the P wave is upright for representing the right atrium, and then it's the left atrium, which is more downsloping. So the same applies to P pulmonale, which means the P is upright, about 2.5 millimeter in height, and then it comes down sharply as the left atrium. And same applies to the P mitrale, where this is the right atrium, little slope, and then of course left atrium. So what happens if both atria are enlarged? So the normal P wave is unimodal, going up and then coming down, and in V1 it is bimodal, upright and downloading as well. Right atrial enlargement will have the first part going up and the second part, which is left atrium, coming down slowly. Left atrial enlargement is when the first part is small, followed by a plateau, and the left atrium then continues with the upslope and then comes down. So when there is bilateral right atrium, when there is biatrial enlargement, such as right atrium and left atrium, both are tall. So the first part, right atrium is tall, begins to come down, and then it's going up again in relation to the increased musculature and pumping of the left atrium. So the PR interval, this is the onset of the P to the start of the QRS complex. So really it should be called the PQ interval, but it's traditionally called the QRS. And this is when the SA node transmits the action potential across the atrial muscles, then towards the AV node, and then it travels through the AV node. So the conduction rate is 3 small squares to 5 small squares. So 0.12 to 0.20 seconds. If the PR interval is more than 0.2, that is 5 small squares or 1 large square, then this is called the first degree heart block. If the PR interval is less than 3 small square, which is 0.12 second, then it is called a pre-excitation phase of the P wave transmission into the AV node. So if we look at this again, you can see this is the QRS complex, this is the T wave, and this is the P wave. So the P wave, if we start from here, obviously it should be around here 5 small squares. So it is much more than that. So counting this, so this is around 0.32 to 0.34 seconds, which is more than 0.20. So this is a first degree heart block. So all of the P waves are followed by one QRS narrow complex, but there is a delay in the conduction. So this is basically the first degree heart block. Then if you notice a different version of the heart block, where this is the QRS narrow complex, T wave, and then this is the P wave, and the P wave is followed by a QRS complex, but there is a delay. And so that delay is likely to be 0.30. And then the next one is again slightly more PR interval. And then again, there is a third one, which also is even more prolonged. So it is 0.2 and it's 0.36 seconds, followed by a QRS complex. And then there is a compensatory pause. So the P wave, this is the T wave. So the P wave, which is produced here, is not followed by a QRS complex, which is completely missed. And then the next P wave that we have has got a reduced PR interval. So this is called Mobitz type 1. So this is Mobitz type 1, and this phenomenon is called Wenckebach phenomenon. So as you can see, from the baseline, each PR is prolonged until PR 0.34 second here, and then there is a QRS is dropped in this part, followed by a shorter PR interval. There are two other conditions. WPW syndrome, Wolff-Park, and the Lawn-Cannon-Levine syndrome. So it has a short PR, as you can see, that the PR interval is actually about 0.12 seconds. And so this is a short PR and followed by a an upslurred part of the QRS complex. And the QRS complex is slightly wider than usual. And so this combination is said to be Lone-Ganong-Levin syndrome, Wolff-Parkinson-White syndrome, or this happens usually when there is an anatomical re-entry produced. And so the PR is less than 0.12 second, the QRS is broad, and then there is a slurred upstroke of the QRS complex. So this is pre-excitation. Same applies here. So you could actually see the entire 12-lead ECG, and this is normal, of course. So when there is action potential produced directly from the AV node, then there is no P wave, which would be from sinoatrial node along the atrial muscle to the AV node. So this is therefore an inverted P, or sometimes it could be absent, and followed by a slurred part of the QRS complex. And this is also called the inverted P. And this is AV nodal rhythm. We should look at also the axis of the heart as the transmission of current takes place. So the classification would take us to normal axis, left axis deviation, right axis deviation, extreme axis deviation, and indeterminate axis. The reason for understanding the axis is to decide to treat appropriately. And the axis is calculated either by the quadrant mechanism. So you find the isoelectric QRS in any lead, and then you measure. Positive would be 0 to 90 would be normal axis. From 90 to 180 on the other side is right axis. 0 to 90 from the lower side will be left axis deviation. And if it is minus 90 to 180, it's extreme axis. It's much more simple to understand the 3 QRS lead method of understanding the cardiac axis. Looking at lead 1, QRS complex, lead 2, and AVF. So if lead 1 has upright QRX and upright lead 2 QRS, then the axis is normal. It doesn't matter what the AVF or the inferior lead suggests. Similarly, if in lead 1, the QRS is up and lead 2 QRS is down, then it is left axis deviation. If in lead 1, the QRS is down, lead 2 could be anything, but AVF is up, then it is right axis deviation. If the lead 1 is down, AVF is down, then this is an extreme lead. So what is associated with right axis deviation? It could be in a very young person or very obese person. It may be associated with right ventricular hypertrophy or with COPD or pulmonary embolism. It can also be associated with acute myocardial infarction, could be associated with right bundle branch block and posterior fascicular block. So there are a number of things which the right axis deviation can be associated with, including normal variation. It's usually COPD or it is some sort of a right ventricular lesion. What is associated with left axis deviation? This is associated with some sort of cardiac comorbidity. So it is almost never normal. So on rare occasions, age, gender, pregnancy may cause this to be present without any illness. It's normally associated with left ventricular hypertrophy, inferior AMI, when there is pacing produced, left bundle branch block, and so on. It also is associated with hyperkalemia and emphysema. So just these two patterns, right bundle branch block is RSR in V1. And if you notice that the QRS is slightly broad with an upslope of the T wave. So the basic diagnosis of right bundle branch block in V1 is RSR. Left bundle branch block, if you look at V1, there is this W abnormality like this. And similarly, it would be in V6. So V1, there will be W, and V6, there will be M. We go on to atrial fibrillation now. It's an irregularly irregular tachydysrhythmia, chaotic fibrillation waves, and then P waves are disorganized or may not be visible. It's usually present at age 40 if it is produced, and 25% of people will have a lifetime risk. And it's due to arterial embolism, CCF, stroke, cardiomyopathy. Complications of AF would be hemodynamic instability, cardiomyopathy, and of course, it would be ischemia, wherever it is transmitted to. So it is an irregularly irregular tachydysrhythmia, chaotic. So atrial fibrillation is just quivering of muscles of the atrium, and therefore there is no effective pumping. The physiological mechanism would be that it's a micro re-entry sort of phenomenon of action potential causing flickering movements of the atrial muscles near the pulmonary veins. Could be due to damage produced by radio frequency ablation, and these could be wandering wavelets. So what could cause atrial fibrillation if there is no pre-existing cardiac comorbidity? Thyrotoxicosis, misuse of T4 as in athletes, pulmonary embolism, alcohol and some drugs, particularly cocaine, myocardial ischemia, atrial enlargement, cardiac contusion, recent surgery such as post-CABG surgery, hypothermia, and so on and so forth. So there are many causes and triggers of atrial fibrillation. Features: irregularly irregular rhythm, there is no P wave, absence of an isoelectric baseline, variable ventricular rate, usually ventricular rate is around 110 to 160. QRX complexes are usually less than 3 small squares, unless there is pre-existing, so to say, blockage. Bundle branch block. Fibrillatory waves may be present, may be fine, and the amplitude could be 0.5 millimeter or coarse. And so if you see this, this is the picture of atrial fibrillation. So QRS probably this is T and this is P. This is where P should be. So there is no P wave, effective P wave at all. And so the ventricular rate is 300. So the ventricular rate is 300, 150. This is about 130 or thereabouts. This is atrial fibrillation. Atrial flutter is slightly less fast and it is a sawtooth appearance. There is no picture of proper P wave. And one can see that the P waves could be part of the S wave beginning of the T and this. So these all three, this one, and that one are all sort of say abnormal P waves like a saw. So these are atrial flutters. Classification of AF. With the first episode, if it is discovered, you call it AF. If this is recurrent AF, then there are more than 2 episodes. Paroxysmal AF, self-terminating episode in less than 7 days. Persistent AF, not terminating and lasting beyond 7 days. Long-standing AF is when it has lasted for a year. Permanent AF, when a person doesn't want any treatment and that it has gone on for 1 year in which rhythm control interventions are not used. When someone has paroxysmal atrial fibrillation, if it is more than 48 hours, then it's unlikely to spontaneously revert to sinus rhythm. So these are the guidelines through which we make a decision about how to treat the So the risks of embolic stroke caused by the spread of the atrial fibrillation clot, which usually gets accumulated in the left atrial appendage, the risks of stroke are significantly high. Risks of bleeding are very much less. If there is valvular disease, then one should be treating this patient with some sort of a vitamin K antagonist anticoagulation. The anticoagulation strategies may include DOAC or NOAC, antiplatelets, and also other forms of modern antiplatelets. There are many screening scores available to see the risks of bleeding versus risks of stroke. So there are fewer risks of treating patients with anticoagulation or NOAC or DOAC, since ischemic stroke are 80% and hemorrhagic stroke are 15 to 20%. So the CHADS-2 score relates to congestive heart failure, hypertension, age, which is more than 75, diabetes, and stroke or TIA. So the score is increased to 2, +2, if there's a past history of stroke or TIA. This is CHADS-2 score. CHADS-2 DS2 FAST score. So 0 is low level of stroke, 1 is moderate risk, and more than 1 is high risk. So it is congestive heart failure, hypertension, age, which is less than 65 is 0, 65 to 74 is 1, 75 plus 1 is 2, +2. Diabetes, and if a person has had stroke or TIA, and or thromboembolism, then you either add +1 for stroke or TIA, or 2 if both stroke or TIA and thromboembolism are present. VASC relating to vascular disease is prior MI, peripheral arterial disease, aortic plaque. Age would be 65 to 74, and there is a gender preference. Female have a higher risk, and they will be scored as +1. Then there is an atria bleeding score, and so that relates to anemia, severe renal disease, age more than 75, bleeding history, hypertension, and in this atria bleeding score, less than 4 is low risk. Hemorrhage score, which is major bleeding risk. H is hepatic or renal disease. E is ethanol or alcohol abuse and drugs. M is malignancy. So DOACs for AF. So there are a few well-known DOACs. So either they are inhibitors of 10A, or like rivaroxaban, apixaban, and edoxaban, or inhibitors of 2A, such as dabigatran. NICE recommends DOAC if the CHADS-VASc score is 2 and more. A vitamin K antagonist is advised if a DOAC is contraindicated or not tolerated. There are 2 specific reversal agents now available, approved for reversal of DOAC. So idarucimab, which is a monoclonal antigen and binding to antibody, is for reversal of a direct thrombin inhibitor 2A, which is dabigatran, or andexanet alpha, which is a modified and inactive factor 10A inhibitor, and it is used when there is an intolerance or excessive use of apixaban and rivaroxaban. Thank you very much for patiently listening to this technical presentation, and hopefully when we have covered the next part, you will have begun to identify the pattern, comparing with what is normal, and then make the diagnosis reliably of ECG.